Please take it away, Ush.
Thank you for the organizers for inviting me today to speak on maternal RSV immunization program, learnings from 2025 and 2026, and then looking forward to 2027. I too would like to acknowledge traditional custodians on the lands on which we meet today and extend my respect to any Aboriginal and Torres Strait Islander people here today or online. These are my conflicts of interest. And today I'm going to speak to you about RSV and then 2025 RSV Maternal and Infant Protection Program. Look at the evaluation in terms of uptake, implementation, effectiveness, impact, and then some real-world data on maternal immunization, and then focus on 2027 and beyond. I don't think I need to tell this audience why we focus on RSV, but it is the most common acute respiratory infection in young children, with 50% infected in the first year and almost all by second year. It causes significant morbidity and mortality globally in children under 5 years of age and has significant impact on emergency presentation and primary care. Importantly, there are also long-term sequelae from RSV infection in terms of viral-induced wheeze and asthma, and especially so if infants are exposed in early infancy. The risk factors are, if you're younger, the greater the risk. The burden is 2 to 4 times higher in Aboriginal and Torres Strait Islander individuals, and other underlying medical risk factors shown there. But importantly, almost 80% are healthy children with no underlying medical conditions. So focusing on the 2025 immunization program, under the National Immunization Program, maternal immunization became available for pregnant individuals from 28 weeks onwards from the 3rd of February 2025. Alongside this, each state and territory had a nirsevimab program, of monoclonal antibodies, which young infants who were not exposed to the maternal vaccine could receive the nirsevimab, or children who had underlying medical conditions I previously discussed, and also children entering the second year of life that remain at high risk of RSV infection. And then each state and territory had different nirsevimab programs with their start date, end date, whether it was an year-round seasonal program, how you could access nirsevimab, and whether they had a catch-up cohort or not. So moving on to RSV program, I'll look at 3 key domains, which include uptake and implementation, effectiveness, and impact of the program. So how have we done? This is data from NCS, which looks at the number of doses that have been given across Australia in terms of jurisdiction. What it shows is we've delivered more than 175,000 doses of Abrysvo, maternal vaccine, and then more than 50,000 doses of nirsevimab. However, the actual coverage rates are not evident, but anecdotally, it's between 50 to 60% in most cases, most states. It does show that we had early coverage with introduction of the maternal vaccine within a short time frame. There are some variations in terms of geography, but what we don't know is the variation across jurisdictions in terms of what the coverage is like between urban and regional remote regions, what the coverage is in terms of socioeconomic status, but also whether there is this difference between coverage in ethnic or cultural groups. When you look at implementation or Abrysvo uptake by provider settings, over 2/5 of the vaccinated females received their doses in general practice settings, and a substantial percentage were vaccinated in hospital, pharmacy, or state and public health units. It does highlight the importance of embedding maternal vaccination within antenatal care pathways. I'm just going to shift to WA just in terms of how we went with our coverage. And what this shows is the maternal vaccine and Abrysvo maternal vaccine and Beyfortus or nirsevimab coverage in our population, divided by or shown by birth, the catch-up cohort, and then the Aboriginal second season. In WA and Victoria, First Nations children or Aboriginal and Torres Strait Islander children were recommended to have RSV immunization or nirsevimab if they were entering their second RSV season, regardless of whether they had risk conditions or not. We achieved almost 60% of maternal RSV immunization in the birth cohort. In WA, we had a nirsevimab program in 2024, and so there was concerns that in the catch-up cohort, this might be overlooked because we had two different RSV immunization products that were available. And so what we saw is we had an 8% drop in coverage in the birth cohort, almost 20% in our catch-up cohort. So these are the children that would be eligible for nirsevimab, and then an even drop in Aboriginal children. So overall, it meant that 20 to 40% of eligible infants remained unprotected. Now, moving on to effectiveness, I'm going to provide data from two studies, the PEDS FluCAN study and Street and Slide. I apologize for those who are at the RSV Impact talk today. You'll see the slides again. And these studies provide us insights into effectiveness and impact of the 2025 RSV MIP program. So the PEDS FluCAN network is a group of 23 sentinel hospitals across Australia, with 13 hospitals in this study that contributed pediatric data, 8 pediatric only, and 5 mixed adult and pediatric sites. The PEDS FluCAN network recruits RSV, influenza, and COVID cases and controls. The objective of the study was looking at effectiveness of the RSV prevention strategies, and we looked at children under 2 years of age. It's a multi-center study, case control design, and uses a test negative design. What we saw was in this cohort, which is children that were born after 17th of February 2025, so 2 weeks after the RSV program, maternal RSV program was introduced, we had 35% of the children that were RSV positive that were exposed to either the maternal vaccine or nirsevimab, 72.2% coverage in the negative, so RSV negative children, and 51.6% of maternal coverage. In terms of effectiveness, for overall, which includes either you've been exposed to maternal vaccine or nirsevimab, the effectiveness was 82.6%, 81.5% for maternal only, and 89.6% for nirsevimab alone. We looked at relative effectiveness, which is a comparison looking at whether there's a difference between maternal and nirsevimab vaccine, and we didn't see, or this wasn't significant. We also looked at impact, where we looked at the RSV notifications within the database or the PEDS FluCAN network for 2024, and then compared that to 2025 for weeks 14 to 48, and excluded WA and Queensland because both of these states had nirsevimab programs in 2024. And what we saw was impact in terms of reduction in RSV cases in especially the less than 3 months of 43%, 20% in 3 to 6 months, and then about 10% in less than 12 months, with an increase in the 1 to 2 year olds and 2 to 5 year olds, and this would be children largely not eligible for RSV products. This is some WA data which looks at population level impact. On the left is the RSV notifications, and on the right is the RSV hospitalizations. And using data linkage, we've been able to show impact. RSV was made notifiable in Western Australia in July 2021. And what this does is compares 2022, 2023 to 2024 and 2025. So the red line is 2024. And the orangey line that you can see or maybe can't see is 2025. And what we saw was a 61% reduction in RSV hospitalization in 0 to 3 months, 54% in 3 to 5 months, or 6 months, and then a 52% reduction in 6 to 11 months in terms of RSV hospitalizations. So I'm now going to shift to the Streeton study, and as part of Pfizer's commitment to post-marketing surveillance, we had an opportunity to work with them to do a maternal vaccination effectiveness study nationally in infants less than 6 months of age. The study recruited infants less than 12 months of age, but I'm going to show you the data for infants 6 months by infant age, RSV subtype, and vaccination characteristics. We had 9 hospitals across 6 states and territories that were involved in this study. The primary objective was looking at vaccine effectiveness against lower respiratory tract disease. And in this population, we had 30% of infants that were born to mothers who received RSV vaccine during pregnancy compared to 64% in the control infants. Here we see a further breakdown among broader outcome of ARI, and then within the LRTD group, a subset outcome of severe LRTD hospitalization. I'm now going to show you the vaccine effectiveness against LRTD hospitalization by infant age. And our primary objective of VE against this was 77.8%, and the point estimates were qualitatively higher for the subgroup of infants 0 to 3 months at 80.2%, and again, infants 0 to 2 months of 86.3%, which is expected. For RSV ARI hospitalization by infant age, the overall vaccine effectiveness for 0 to 6 months was 80.8. You may recall or you may not recall from the PIDS FluCan data, our cohort, for our cohort in the children that were born after the 17th of February for maternal vaccination, it was 81.2%. So very close point estimates for ARI, which is what the objective was for the PIDS FluCan study. Similarly, for severe LRTD, we're seeing high point estimates in the 80s across the different subgroups. And then looking at the vaccination characteristics, what we did was look at effectiveness depending on when the vaccination was given during pregnancy, what the interval was between vaccination and birth, and then the infant's age at the time of RSV exposure. Here we present VE data against LRTD hospitalizations according to the 3 characteristics. And what we saw is high point estimates between 75% to 80s, mid-80s across the different vaccine characteristics. We also looked at RSV subtype. Only 2 hospitals do RSV subtyping, and what we saw is that the vaccine effectiveness is maintained for RSV A and B across ARI and lower respiratory tract disease. So I'm just going to shift a little bit to real-world data in terms of how we compare our data to what's happening and what has been reported across different countries. So when comparing real-world vaccine effectiveness across different settings, such as Argentina or US, both of these countries have seasonal programs as opposed to ours, which is year-round, and both of the countries start immunization from 32 weeks gestation. UK and Australia have year-round programs that both start at 28 weeks gestation. What we see is VE is higher everywhere and trending from approximately 60 to 80%. VE point estimates appear to be slightly higher in settings that are where we're vaccinating from 28 weeks compared to those that had the 32-week start for their immunization. But more data and time will be able to provide evidence for further support. Similarly, VE is higher in the first 90 days compared to the first 180 days of life, but that is expected. You would expect higher protection in the early infancy. I'm just going to present some work that was presented by Dr. Conal Watson, who is here from UKHSA at the ResVNet meeting. And this is some data that we haven't been able to show in Australia yet, but with time we'll be able to show. And what they did in this study is looking at the maternal RSV vaccination effectiveness by the time of vaccination to birth, but really looking at what happens between the 0 to 14-day window period in terms of vaccine effectiveness, and also gestational week of birth. And what they showed is that you do get protection, even though we have the 14-day window period, there is protection that you see even as early as 10 days. So between 0 to 9 days, the point estimate is very low. But when you look at the 10 to 13 day, the point estimate was about 50%. And then 14 to 27, and increases as time goes on from the time you have your immunization to birth. And the other thing that they showed was that VE was 82.4% for full-term babies, but you had protection in preterm babies as well of 69.4%. And as part of this, I think there was consideration of maybe we should be thinking about whether we vaccinate from 24 weeks gestation to provide some protection to the babies. And then now you're going to shift to what the future for 2027 and beyond. But before I do that, I'm just going to outline what changes have happened in 2026. So we still have our year-round maternal vaccination. In terms of monoclonal antibodies, the program is still state and territory funded with no significant changes. In WA, we did extend our nirsevimab protection for infants that are born out of season to allow them to also have nirsevimab protection beyond the 6 months after the maternal immunization. And we now have RSV adult immunizations that are available on the National Immunization Program for all adults from 75 years of age and First Nation adults, which Dr. Charles or Professor Charles will speak to. One of the challenges is that we have an effective and impactful but yet complicated program, and we saw that 20 to 40% of infants are missing out. This complexity is exacerbated by different funding mechanisms because you've got the National Immunization Program with maternal vaccine, and then you've got each state and territory deciding what to do with the nirsevimab program. And there is variation of epidemiology by geography and time. On another news, and I think Stephen will talk to this, is there's been a legislative change which allows monoclonal antibodies now to be listed on National Immunization Program. So this is a big step in terms of thinking of whether they can be extension of the immunization program in terms of how we can better protect infants that are missing out. So when thinking about 2027 and onwards, there's still work to be done. There's work around equity. How do we better target strategies to improve access for underserved populations, regional and remote communities, and those groups that have lower antenatal engagement? What do our delivery models look like? How can we better embed vaccination more consistently in our routine antenatal care pathways or postnatal care pathways to ensure that those that are not exposed to RSV maternal vaccine do get the nirsevimab immunization? And then in the year-round program, ensuring vaccination occurs within the optimal gestational window is essential to optimize infant protection. How do we better monitor using data systems how we are working? How can we better link maternal and infant data to really get an insights on the extent of which the program is working. And then in terms of policy coordination, how do we integrate monoclonal antibodies in the national immunization program? And then thinking about long-term follow-up in terms of effectiveness against asthma and wheeze. So in summary, I hope I've shown you that the maternal vaccination program is working, but there's still work to be done. In 2026 and 2027, we can do better by continuing to promote maternal vaccination, but also coordinating policy and alignment of monoclonal antibody programs across states and territories. And longitudinal data is always needed to understand how we're going in terms of effectiveness of the year-round maternal vaccination. These are my acknowledgements, and that's the end of my talk. There are lots of people that are involved in the work that I have presented today.
Thank you, Ush, for a fantastic talk. This is Ush's third talk today, so I think she's done amazingly well. Okay, any questions in the room? Maybe while you're... Oh, yep, one question. Can we have the roving mic, please?
Hi, Ushma. Jean-Lee Kimoy from NCS. I was just interested in your slide where you compared the WA coverage between 2024 and 2025, where you showed the coverage, was 78% in 2024 when you just had the nirsevimab program, and then that fell to 70% with the mother-infant protection program in 2025. Just wondering what your thoughts were as to why the coverage was lower in 2025 compared to 2024, whether there was, was this related to the complexity of a hybrid program, and in general, what are your thoughts about having moved from a wholly nirsevimab program to a hybrid program, and was that the right move?
I think it was around the complexity of moving from one product program to a hybrid program in terms of thinking about which people you need to promote the immunizations. And it may be that we are doing maternal immunization and forgetting the catch-up cohort, because that was the most important, I think, where you saw that significant drop in coverage. So I think complexity and confusion probably were the things to think about in terms of whether that was the right move or not. I think it's fantastic that we have a program on the national immunization. We have a national immunization program that protects our infants. And then it's to look at how better we can do that. How can we protect each infant at the right time with the right product?
And it's also very interesting, the French have conducted a study that they presented at ESPID where comparing nirsevimab and maternal vaccination, finding that vaccination, particularly early, in the second trimester, there was less of a difference between maternal vaccine and nirsevimab the earlier you gave it, sort of earlier than potentially 28 weeks. So, maybe that's somewhere we need to head in Australia.
Sorry, was there a question in there, or?
Yeah, it was a French study.
So we're just going to have one quick question from online. Ushma, how long does the vaccine protection last, and when are boosters required for mothers in further pregnancies?
So I'll answer the quicker question. So in terms of booster vaccination, there has been a TAGI recommendation now that each pregnancy RSV vaccination is recommended. So that was easy. In terms of durability or duration of protection, we know that that protection is up to 6 months of age. And for maternal vaccination, that is going to be higher in the earlier months because of the way the maternal vaccines work. And for nirsevimab as well, is up to 6 months of age. What we don't know is beyond 6 months, what that protection looks like. From the work that I didn't show the slide, but Hannah's work around maternal vaccine and nirsevimab in terms of protection for those out-of-season babies, so the babies that are born in spring and summer, that would be beyond that 6-month window period, that are going into the RSV season. For places that do have RSV peaks in the winter months, the recommendation was to then add nirsevimab to protect them if the families choose to have that additional protection.
All right. In the interest